Thanks for giving us the opportunity to present the Alex 3, so the third generation of our Allergy Explorer. So in today's presentation, we'll be looking at the rationale and the technical aspects of Alex 3. We'll then look at the allergens that have been removed, moving from Alex 2 to Alex 3 in a bit more detail, together with the arguments and rationale behind those decisions. We'll then look at the new allergens that have been added to the platform, and finally we'll also discuss the benefits of these Alex 3 features and what benefits they offer to the clinicians. So the rationale for the product update, if you like, was to ensure that the Alex 3 remains at the forefront of innovation and sets industry standards. The panel design was guided by a data science analysis approach that focused, or that used, approximately 1 million results from the Alex 2 setup. And the aim for this was to reduce redundancies by looking for at cross-reactivity patterns, with the aim of keeping as much information as possible with as few results as necessary. We wanted to replace extracts with molecular allergens to increase the accuracy as well as the reproducibility of the assay. And finally, we also removed allergens that showed very limited diagnostic benefit. Now, if we look at the key features of the Alex 3, we'll see that it's a very comprehensive assay. So it contains high relevant allergen sources from approximately 85 allergen families. The Alex 3 also contains both extracts as well as molecular allergens, which don't interfere with each other. Rather, they complement each other to provide a more clearer as well as comprehensive sensitization profile. The test is specific as it provides quantitative results for both specific and total IgE, and this high specificity and sensitivity ensures accurate detection of the patient's sensitization profile. And finally, the Alex 3 provides a clear answer with only one test result, so that means it's quite efficient. We have an integrated interpretation software which helps translate these results into meaning and also supports in the decision making with regards to sort of therapeutic steps and personalized allergy management. An important addition to the Alex 3 is the quantitative determination of total IgE within the range of 2 to 1,000 kilounits per liter, as it's been directly calibrated to the WHO standard. Within the range of 1,001 to 2,500 kilounits per liter, total IgE is still determined semi-quantitatively, as it is in the Alex 2, and this is essentially due to the higher variability we see in the assay for this quantification range. Another important feature that's been added to the Alex 3 is the inclusion of a sample pipetting control, and this is based on the detection of a specific ubiquitous human serum plasma protein. And the idea of including this is that we'll minimize the number of false positives that are due to the absence of analyte, which should ultimately increase the reliability of the assay. And these sample pipetting controls can be found on the bottom hand side of the array. And here they're sort of being processed, but generally they're visible also with a naked eye, so you get your colorimetric kind of readout. And it's just to ensure that the serum sample is essentially being pipetted correctly to the array. So the Alex 3 contains a total of 107 unique allergens that are only available or exclusively available through our platform. And these allergens provide additional diagnostic benefits and allow a more accurate determination of the patient's sensitization profile. So a few honorable mentions, if you like, would be the seed storage proteins from almond and coconut. We have the plant defensin, APG7 from celery. We have the various casein subfractions, so not only BOST-8, we've included BOST-9 through to BOST-12. We have a cyclophilin from BETV7 and also ZEA-M1, which was a specific request from the South African market, actually, for the corn pollen allergen, major allergen. So in total, the Alex 3 contains 218 molecular allergens and 82 extracts, providing a comprehensive and well-balanced allergen panel, which features inhalants, food allergens, we've got contact allergens, as well as insect venoms. And this provides a globally relevant sort of allergen profile. Now, the allergen composition has been optimized, if you like, when we're moving from Alex 3 to Alex 2, from Alex 2, to Alex 3, with certain extracts and molecules removed, and others have been added. And in the next few slides, I'd just like to focus on sort of the allergens that have been removed from the Alex 2, moving to the Alex 3, and also sort of the rationale and the thinking behind that decision, if you like. So one approach to remove extracts from the Alex 3 was to see if the allergen source is covered, if you like, adequately covered by molecular allergens. So if there was very good coverage of the allergen source with molecular allergens, then that was reason to remove the extract. And if coverage wasn't particularly complete, then we decided to keep the extract on the platform. So a very good example for this would be spelling pellitory. So this is an allergen source that is known to contain molecular allergens from various protein families, so NSLTPs, polcalcines, as well as profilins. And on the right here, we have a APSET plot. So just briefly, for those who are not familiar with it, so the green bars, if you like, on the left-hand side indicate the number of people that are positive for each individual allergen, whereas the pink bars on the top, if you like, represent the number of patients that test positive for different allergen combinations. And the combinations of the allergens are illustrated, if you like, with these interconnected dots. So in this example, we'll see that the highest number, if you like, of co-sensitization was actually observed for BETV2 as well as FLIP-B12. But if we do look at this APSET plot in a bit more detail, we'll see that quite a large number of patients tested positive for PAR-J, which is over here. So for the extract, if you like, of spelling pellitory, without testing positive for any corresponding molecular allergens that are known, at least. So if you're looking at the polcalcines and the profilins. What this suggests is that the allergen extract contains additional molecular allergens that have not yet been characterized. And if those weren't, and if we excluded, if you like, the extract, we'd be missing those sensitizations, which was the reason why we decided to sort of include or to keep the PAR-J extract on the chip. In contrast to spelling pellitory, where the extract clearly offers a diagnostic benefit, if we look at the SIN-D extract from Bermuda grass, we'll see that this doesn't actually offer any diagnostic benefit. And the reason for this is the majority of people that test positive for SIN-D1 extract also test positive for the SIN-D1 molecular allergen, which actually argues for the removal of this extract. And this was an extract that has been removed from Alex 3. Oops, sorry. Another approach for the removal of either molecules or extracts was to look for surrogate markers that can be used to detect sensitization to specific protein families. So this approach is very suitable, if you like, for protein families that show a high level of cross-reactivity. Example of these would be the profilins and the PR10s. Whereas for protein families with relatively low cross-reactivity, sort of your seed storage proteins or your SLLTPs, this isn't the best way to go, if you like. And this is exemplified in the coming slides. So if we look at the PR10s, we'll see that Alex 2 contains a total of 10 PR10 molecules. And again, looking at the APSET plot, we'll see that this protein family is actually demonstrates a high level of cross-reactivity. And this is indicated here by the large number of sort of connected dots, this interconnected dots. What we also see is that monosensitization to BETV1, so birch pollen, was actually detected in quite a large number of patients. Whereas if we look at carrot, so Dowsy1, carrot, beech, as well as hazel pollen, we'll see that very little or no monosensitization is actually observed, with the majority of patients that test positive for these allergens also testing positive for other PR10s, other molecules, within this protein family. And that suggests that one of the other molecules, namely BETV1, one of the other PR10 molecules, could actually serve as a surrogate marker, to detect sensitization to carrot, beech, as well as hazelnut pollen, or hazel tree pollen. If we look at the 2S albumins, on the other hand, we'll see that the Alex 3 contains a total of 13 allergens. And just by looking again at the APSET plot, we'll see that this protein family demonstrates a very limited level of cross-reactivity, and that's indicated by these large number of single dots, which is indicating monosensitization to the individual molecular allergens within this family. And in this kind of scenario, it's important to test for as many kind of representatives from the same protein family to try and identify the culprit allergen. And the reason for this is because 2S albumins are particularly associated with increased risk of anaphylactic reactions. So it's important to test for many different members of the same family to identify the actual underlying allergy and culprit allergen. Finally, any allergens that showed very limited diagnostic benefit, and that was mainly due to very low prevalence in the populations, were actually removed from the test. So, examples of these would be sort of your oregano, the caraway seeds, as well as bell pepper. So, in addition to optimizing, if you like, the panel composition, moving from Alex 2 to Alex 3, we also included an additional 53 new allergens onto the Alex 3 panel. And details on the allergens that have been added can be found in our online magazine. So this is an in-house magazine. It's available on our website, and also in our recent publication in the International Journal of Molecular Science. So that gives you a very good detailed information about the allergens that were added and the reasons behind that. And in this few next slide, I'm just going to cover a few of them just as examples mainly. So we've got QA1. So this is a PR10 from oak pollen. It's related to BET-V1, but the level of cross-reactivity to BET-V1 is quite low, which means that BET-V1 doesn't serve as a very good surrogate marker for identifying sensitization to oak pollen. The reason for including it, if you like, on the Alex is essentially because it's highly relevant in non-birch countries, where it contributes both to respiratory as well as food allergies. And also there's immunotherapy available specifically to oak pollen, which argues again for the inclusion of this particular molecular allergen on the panel. ZAM1, so this is a beta-expansine, which accounts for approximately 4% of the protein content in the pollen. It's a highly stable molecular allergen, and it is able to retain its reactivity for prolonged periods of time, as well as following sort of processing, if you like. The rationale for including it is it's a maize pollen allergen, and as such is a key diagnostic marker for identifying sensitization to maize, as well as cross-reactivity to other grass pollens. And it may in fact help identify hidden sensitization to maize pollen, especially when other grass pollens are negative, let's say your flippy 5s, flippy 1s. RPM2 is a hyaluronidase from honeybee venom. So this is an enzyme that facilitates the spread of venom at the site of injection by breaking down the connective tissue. Sensitization rates for RPM2 range anywhere between 28 and 60% in bee venom allergic patients. And the rationale for including it is, again, it enhances the diagnostic sensitivity of honeybee venom allergy, and it can also serve as an indicator for venom immunotherapeutic decisions. RPG7, so RPG7 is a plant defensin that has a high level of cross-reactivity to RV1, which is the major mugwort pollen allergen. It's essentially only found in the celery tuber and also in the seeds, and is resistant to heat as well as digestion. So there's a clinically relevant cross-reactivity, if you like, or cross-reaction between mugwort pollen and vegetables and spices, which is referred to as the celery mugwort spice syndrome. And the theory here is that the missing link within this sort of syndrome could actually be RPG7. And the rationale for including it additionally is because plant RPG7, like a plant defensin, is typically underrepresented in extracts. So obviously, if you do any kind of testing with an extract, you're likely to get a false negative result due to the fact that this particular allergen is underrepresented. Again, arguing for the inclusion in an allergy-based test. Finally, we have the alpha-gal. So alpha-gal syndrome is an acquired allergy that's characterized by a delayed onset following the consumption of red meat. Primary sensitization is thought to be due to tick bites, which introduce the alpha-gal carbohydrate into the bloodstream. and then you'll get production of obviously IgE antibodies against that invading carbohydrate, if you like. Diagnosis is generally challenging, so skin prick tests appear to be quite unreliable. And if you do any oral food challenges with red meat, obviously it bears the risk of inducing a severe anaphylactic reaction. As such, the detection of alpha-Gal specific IgE represents the most reliable tool. And due to this increased importance, if you like, of this allergen and this particular syndrome, alpha-Gal has now been included on the ALEX3 chip, and that's just illustrated here in this little button here, or this little feature that's highlighted here. Now, if we turn our attention to the seed storage proteins, we'll see that a large number of additional molecules that belong to this protein family have been added to the ALEX3 test. So when we're talking about seed storage proteins, the three major subfamilies, if you like, it would be the 2S albumins, the 7,8S globulins, as well as the 11S globulins. And if we just look at the 2S globulins, we'll see that 2 additional allergens have been added to the ALEX3 platform. So pecan as well as pine nut, bringing the total number of 2S albumins to 13. For 7,8S globulins, we've added a total of 6 new members of this family from various sources, bringing the total number to 12. And if you look at the 11S globulins, we've added again pecan as well as almond, and that brings the total number of 11S globulins available on the platform to 8. And we'll just look at a few of these, just out of interest mainly. So these are the pecan nut allergens. So they show very high cross-reactivity with the walnut counterparts. So essentially, carry 1 is homologous to Jugar 1, carry 2 to Jugar 2, and carry 4 to Jugar 4. And the reason for including these in the ALEX3 makeup, if you like, is to enhance the in vitro diagnosis of pecan allergies, which ultimately will increase test specificity and also enhances patient risk assessment, as these are sort of thermostable allergens associated with increased risk of anaphylactic reactions. Prudu-6 is an 11S globulin from almond. It shows low to medium levels of cross-reactivity with its relatives in other tree nuts. Typically, 11S globulins are the most abundant seed storage protein in nuts. They're not glycosylated, so we don't have the issue of CCD interference and the resistance to heat and digestion. And as Prudu-6 is a dominant allergen in almond allergy and has been associated with, again, increased risk of anaphylactic reactions, it makes sense to add it to the platform. Also, almond sort of butters, if you like, and creams are being used increasingly more often in sort of baking, as protein substitutes, etc. So it's sort of an potentially emerging allergen source. And finally, we have Maki1 from macadamia nut. So this is alpha-herpinin, which shares approximately 50% sequence identity to Jugar2 for walnut. The antimicrobial peptides that have sort of a very conserved structure, if you like, which obviously contributes to them being heat as well as digestion stable. And the reason for including Maki1 into sort of the ALEX3 would be as it serves, or it may serve as a key indicator for systemic reactions, and it highlights the importance of incorporating Maki1 into the diagnostic workup. So the reason for including such a large number of seed storage proteins on the ALEX3 platform is essentially as it helps with risk stratification. And this is nicely illustrated in this sort of figure here. So we see on the right-hand side, we have the seed storage proteins. They typically exhibit sort of low levels of cross-reactivity, and they tend to be stable to both digestion as well as heat. And they're typically also associated with a higher risk of systemic reactions. And as I already mentioned, in this scenario, it's important to test for a large number of different members of the same family to identify the culprit allergen, which is obviously going to help you further down the line with the appropriate sort of therapeutic approach and strategy. On the other side of the platform, we have your profilins, or the PR10s. These are typically characterized by a high level of cross-reactivity. They also tend to be unstable or labeled to heat and digestion, and as such, typically associated with mild clinical reactions, if you like, such as oral allergen syndrome, or sort of your birch pollen related reactive or allergic reactions. So the take-home message from this slide is essentially, if you look at the biochemical properties of the different protein families, it gives you quite a good indication as to whether this allergen is going to be associated with sort of high risk or low risk. So the ALEX3, just like its predecessor, the ALEX2 offers CCD inhibition by default. So just to introduce CCDs for those of you who are not sort of familiar with them. So CCD stands for cross-reactive carbohydrate determinants. They're essentially sugar moieties that are found on allergens that are extracted from various sort of allergen sources, if you like, so plants, insects, as well as crustaceans. CCDs are able to induce the production of IgE, but until now, I don't think there have been any reports where they show that they elicit sort of a clinical symptom, so they tend to be considered as clinically irrelevant. However, in the sense of allergy diagnostic, they can be quite challenging because if you're having CCD-specific IgE antibodies, you get the impression it can lead, to false elevated or false positive results, which gives a false impression of polysensitization. And this obviously has knock-on effects when you're talking about accurate diagnostics, as well as any subsequent sort of treatment strategies you might be considering, such as immunotherapy, for example. It might all be false positive, in which case a treatment won't actually benefit. And this is nicely exemplified in this figure. So this is a serum sample. It's clearly positive for CCDs or for CCDs, which is illustrated by a marker for CCDs, this homocell F. It gave a nice positive result. And this positive result resulted, if you like, in additional 60 plus positive allergens or false positive results. And when I say here false positive, I mean in the context of there was no corresponding clinical picture. And the next slide is the same serum sample, but this time the testing was performed on the ALEX, but in the presence of CCD inhibition. So the CCD marker, if you like, came back negative, nicely illustrated here. And this actually resulted in the rest of the it reduced the number of positive signals from more than 60 to just 3, with only the venoms returning a positive signal in this particular case. So in summary, the ALEX3 contains new features, so namely the quantitative determination of total IgE within the ranges of 2 to 1,000 kilounits per liter. The number of molecular allergens has been increased and the number of extracts has been decreased to help improve the specificity, accuracy, as well as reproducibility of the assay. CCD inhibition is offered by default, and a sample pipetting control has also been added, which should ultimately help improve the reliability of the test by reducing the false positives due to the lack of analytes. So the key question is, how do these features that are present on the ALEX3 actually translate to benefits for the clinician and for the physician? And we'll go into this in the coming slides. So, as I said, ALEX3 provides you 300 results in one single test, which provides an almost complete picture of the patient sensitization profile. So there's no need to pre-select any allergens based on sort of the anamnesis from the patient or recollection. And also there's no need for multiple visits to the doctor. You have one test, you get all your results in one single step, and you can move forward with that diagnosis. In addition, ALEX is the only commercially available allergen test that blocks CCD specific antibodies by default. And this obviously increases the specificity of the assay, as you're only getting the true sensitization reported without any CCD interference. And ultimately, what this does is it saves time for the clinicians, which allows the clinician also to sort of address and see more patients. And it also increases patient satisfaction, if you like, and conformity. Now, even though extract-based diagnostics are sort of established a diagnostic tool, they're not able to differentiate between the different allergic proteins. And the reason for this is that extract is sort of a complex mixture. Within that mixture, you're going to have allergic components, you're going to have non-allergic components, and you're also going to have CCDs. So it's impossible really to identify the culprit allergen, if you like. Additionally, the extracts tend to show qualitative as well as quantitative variations. So you might have certain components that are missing or that are underrepresented, and this can obviously lead to issues with reproducibility. On the other hand of the spectrum, you have the ALEX results or the ALEX test. So the ALEX test uses molecular allergens, which are essentially highly purified single allergic proteins. And these have either been extracted from the natural source or they've been produced through recombinant technology, if you like. The benefit of the molecular allergens is they're typically well characterized qualitatively as well as quantitatively standardized, which increases the accuracy as well as reproducibility of the assay. And this ultimately allows for a more precise identification of the specific allergen, which then sort of translate into, more personalized, if you like, allergy management and treatment. With the ALEX component results, a doctor can actually predict severity of allergic reactions much more accurately. And this is coming back to the sort of table I showed you before. So if a patient returns a positive result for the PR10 from peanut, the RAH, then most likely the result, the sort of symptoms are likely to be sort of quite mild, something like oral allergy syndrome. Whereas if the patient returns a positive result for one of the seed storage proteins, then obviously there's an increased risk of a systemic anaphylactic reaction, in which case you might prescribe sort of an adrenaline pen that should be kept at hand for such instances. Additionally, an accurate determination of the patient sensitization profile can very much help increase the quality of life of the patient. So the diagnosis of certain monosensitization can actually help make sort of improve, if you like, lifestyles. So it makes lifestyles a bit more flexible. It can also lead to a more tailored kind of allergy management. So examples here, for example, if a patient is monosensitized to CAN-F5, then it might still be possible for the patient to actually own a female dog, as CAN-F5 is only contained within the urine of male dogs. And similarly, if we just look at the eggs, for example, more day-to-day, if you like, if a patient tests positive for one of these egg white proteins, as they're all sort of heat as well as digestion labile, then it's possible for this patient to continue to consume cooked eggs, cakes, etc., and they should only make sure they avoid sort of raw eggs, in which case, their quality of life is improved dramatically as well as nutritional. The ALEX test also gives the physician the opportunity to differentiate between true sensitization and cross-reactivity. So not all clinical reactions are actually due to primary sensitization, and cross-reactivity plays quite an important role here. So you might have a clinical reaction to shellfish, which is in quite a few cases is not necessarily due to primary sensitization to the actual shellfish, but rather to sensitization of tropomycin, which is found in house dust mites, which leads to this cross-reactivity to shellfish. And this is important when you're considering immunotherapeutic approach. Obviously, treating the patient with any kind of shrimp extract or AIT therapy or doing OIT won't be particularly beneficial. In this case, it would be better to sort of treat the underlying sensitization to tropomycin, which would then have the knock-on effect of treating also, hopefully, the shellfish. And this brings me to the last point, which the ALEX test is sort of a better indication for the selection of immunotherapeutic approaches, as it provides specific information at the molecular level, and it identifies the allergens that are responsible for the particular sensitization of the patient. So most immunotherapeutic products are standardized to the major allergen components. And if we do an ALEX test, then we can make sure, we can cross-check, if you like, to make sure the patient is sensitized to the allergens that are going to be present in the immunotherapeutic product, in which case that patient or the therapy is likely to be more efficacious, so it's more likely to result in a positive outcome for the patient. So in summary, we can say that the ALEX is the best available allergy diagnostic tool with the most relevant information based on component resolved diagnostics. It provides a complete sensitization profile for the patient through the availability of 300 results, including total IgE in a single step. And you also have the benefit of the CCD-specific inhibition, which ultimately increases the diagnostic specificity of the test. And this ultimately saves time to the physician as well as the patient, obviously. The Alex is able to identify high-risk allergens, species-specific allergens, as well as cross-reactive allergens, which ultimately improves patient management and improves also patient quality of life. And as already mentioned, Alex can also be used. We can use it for immunotherapeutic monitoring. And this is something we're currently exploring, and there's a few studies currently ongoing in Utrecht in the Netherlands, as well as in Japan and South America. But essentially, the take-home message is sort of a better indicator for AIT decision-making, if you like. And we still have time. Yes, we do. And just as a sort of signing off, I'd just like to sort of present, if you like, a clinical study or clinical case that nicely illustrates how these ALEX3 features actually improve diagnostic outcome and provide more specific kind of diagnostic testing, as well as more information regarding the sort of safety profile, if you like, of the patient. So this is Sabine. She's a 31-year-old woman from Switzerland. She's been suffering from allergic rhinoconjunctivitis since the age of 8. She's a non-smoker. She has no chronic illnesses, and her skin prick test returned a positive result only to mugwort pollen. And her symptoms are typically treated with antihistamine sort of as needed, if you like. Regarding family history, her mother also suffers from allergic rhinoconjunctivitis as well as food allergy to tree nuts specifically. And the current situation is that Sabine suffers from seasonal allergic rhinitis, which predominantly kind of the symptoms occur in late July to September, which is sort of coincides with mugwort season. She's reported sort of episodes, if you like, of itching in the mouth and throat, tightness of the chest, as well as facial flushing after the consumption of dishes with spice mixes. And on 2 occasions, those symptoms actually progressed to generalized urticaria, dizziness, as well as shortness of breath within approximately 20 to 30 minutes of consuming an instant ramen dish. If we look at the ALEX3 results now, what we see is that Sabine tested positive for ADV1, which is the major mugwort allergen. However, the ragweed pollen allergen, so AMP-A1, the major allergen, returned a negative result. Also, no positive results were observed for any of the sort of the allergens coming from NSLTPs, polcalcines, profilins, or PR10s. However, interestingly, all members of the plant defensin family returned a positive result. So you've got APG7, AMPA4, and ATV1, as we said. So the ALEX3 results would support the diagnosis of a mugwort celery syndrome that's mediated by APG7. The patient is at increased risk of recurrent systemic reactions, including anaphylaxis, and the cross-reactivity via the inhalant sensitization to RV1 is most likely the primary sensitization route. So as already mentioned, APG7 is a heat and digestion stable plant defensin from celery. It's structurally related to RV1, and it's associated with a more severe and persistent reaction, in contrast to the PR10 allergens like APG1. And this is nicely exemplified here, where the study showed that the odds of experiencing a systemic or severe anaphylactic reaction was 6 times higher for individuals that were sensitized to APG7. And to confound this, if you like, APG7, as already mentioned, is underrepresented in the whole extract, which means that any skin prick testing or IgE testing based on extract is likely to result in a false negative outcome, which seems to be the case with Sabine, because we saw that the skin prick test only returned a positive result to mugwort. So plant defensins, very briefly, are part of the plant's innate immune system. As we said, they've got these sort of disulfide bonds that obviously contribute or confer high resistance to heat, pH, digestion, and protease digestion. They're identified in many different plants, and they're typically upregulated by stress. There have been case reports that suggest that plant defensins in mango and sunflower seed allergy do play a role, and this was based on inhibition experiments with RV1. As I said, it's underrepresented in extracts from seeds and tuber, which suggests that the inclusion of a purified plant defensin is actually beneficial to sort of the allergy diagnostics and to provide an accurate diagnostic outcome. So in summary, in this particular case, the extract-based diagnosis, so the skin prick test essentially produced a false positive result, whereas the molecular tools with the help of ALEX3 showed that IPG7 is positive and is also the clear culprit in this particular case. She's been advised to avoid celery and use caution when consuming mango and sunflower seeds, and that's essentially due to this potential cross-reactivity. She's been prescribed with an emergency pen that she should always carry with her. And as she showed sensitization to RV1, which is a major mugwort pollen allergen, she would actually be a candidate for immunotherapeutic approach using mugwort pollen. However, as her major allergen from ragweed and BAR1 was negative, obviously immunotherapeutic sort of intervention for ragweed wouldn't particularly be beneficial in this case, and she's been advised not to go down that route. So I think we're well ahead of time. So I'd like to thank you for your time and attention, and I'm very happy to take questions from the audience.
Thank you very much, Doctor, for that informative presentation. I will start with a few questions. What is the prevalence of the cyclophilin allergen? I see this sometimes. So it's the same person who asked, and then they also asked, is it involved in any cross-reactivity?
Yes, so cyclophilins, yes. So we have the B7 now, cyclophilin, and that's considered a pan-allergen. So it's essentially it's a pan-allergen that's found in obviously birch pollen, but it can obviously lead to cross-reactivity to other allergens from other sources, including food sources. And the reason we've included it on the Alex is essentially to try and identify. So you have some patients that are negative to the molecular allergens that are already available on there, so B1, 2, etc. But they come back positive for the extract, and we're thinking in those cases B7 again might be the culprit allergen. And it would also pick up cross-sensitization, if you like, to Mala S13, which is another cyclophilin that's been added to the ALEX3, as well as RH18, which is also a cyclophilin from peanut that's also available on the ALEX3 platform. And the second question you said?
It's asked that, is it involved in any cross-reactivity?
Yes, it would be, yeah. So it's a pan-allergen, so there's a very high level of cross-reactivity. So yes, you would be able to look for cross-reactive patterns, and it might lead to sensitization to sort of allergens from different sources or different allergen sources. Yeah.
The next question: why has the alpha-gal IgE been added to the ALEX? We have many meat protein IgEs. Was there a reason for this exclusion?
Sorry, you were cutting up, so if you could just repeat the question. Sorry.
Why hasn't the alpha-gal IgE been added to the ALEX? We have many meat protein IgEs. Was there a reason for this exclusion?
No, I mentioned it in my talk. The alpha-gal, was it? Yeah, alpha-gal. Yeah. Sorry, I'm just making sure. So the alpha-gal is added onto the ALEX3. So there was a slide. I'd have to wait a minute. I can tell you which slide. Slide 22. So it's all about the alpha-gal that's been added, and it's a feature sort of on the second row on the right-hand side of the test. So we appreciate, as we said, we're showing that this is sort of an allergen of, or a syndrome, if you like, of growing importance. And that's something that was communicated to us, and that's why we decided to include it onto the chip.
Okay, thank you. And then there's another one. I have patients that present with oral allergy syndrome. However, when I do Alex, the Alex is negative for profilin or PR10 for fruits and vegetables. However, when we do prick-to-prick tests, they are positive. Are we missing low positives in these patients?
So the additional testing is done on, so they do testing on the Alex, and then you do testing on a different platform?
On skin prick testing.
In prick tests.
Yes.
Okay, so one possible explanation for this, it could be actually the CCD issue. So obviously extracts, etc., will contain CCDs. And your positive signal that you're getting on your skin prick test might actually be due to the interference from CCDs, as opposed to the actual molecular allergen being the culprit, which would be one reason for the negative test. Additionally, I mean, it could just be that the allergen is not represented or is not available on the Alex chip. So obviously extracts are a mixture of molecular allergens, as well as non-allergic proteins, if you like. So it could be that the patient is reacting to one of those proteins that hasn't yet been characterized and is not available on the Alex chip. So those could be possible explanations for that.
Okay, thank you. The next question. The slide states that QA1 is a member of the PR10 allergen family like BET-V1, but is less so cross-reactive to BET-V1 compared to other oak pollen PR10s. Could you please elaborate on the clinical implications of this lower cross-reactivity for patients in regions where birch trees are not common?
So essentially it's, I mean, on the Alex 2, we never had the QA1, and the reason for this was we were thinking we were able to identify the majority of QA1 or oak pollen sensitized patients with the help of the BET-V1 surrogate. And this isn't the case for due to this low cross-reactivity. Clinically, we'll have to wait and see, I think, is the answer to this, as to what implications it's going to have in areas without any birch pollen.
Okay, thank you. The next question, from what age do they recommend we do the Alex test, and will it be accurate?
Okay, that's a good question. It's come up quite often. So, I mean, the Alex has been tested across essentially all age groups, starting from young children all the way to adults. We do have our, so I can get you the actual, if you're interested, that we've got this, not a statement, but in our sort of technical documentation, I can give you information, detailed information on that. But essentially, due to the fact that in very young children, if you like, the immune system isn't particularly well developed, so it's still developing, you may have sort of lower levels of IgE. So typically, we'd say from about 6 months to 1 year would be sort of, more accurate. But it's safe to use in younger ages. It's just you need to keep in mind that levels might be lower, just due to the fact that their immune system isn't as evolved or developed as in adult individuals. Yeah.
Okay, thank you. Let me just see here. There's quite a few questions. Okay, someone was asking how long does it take to get the results? So the results are out within 1 week. And then also a few people were asking what the cost is for the Alex testing. So the current cash price for the Alex is 4,203 Rand. And then there's another question here. Clearly not a first-line test, but a grade 2 for specialists in the diagnosis of pollen foot syndrome and in difficult to diagnose anaphylaxis cases, can you comment on the sensitivity and specificity in comparison to the immunocap singleplex and component tests?
Yes, I mean, we've got plenty of studies that actually show, so we've compared the studies out there, and I can make the references available, that we've actually compared sensitivity and specificity to immunocap, and we come out very well. So we show very good specificity and sensitivity to sort of house dust mites, peanuts, tree nuts, and we show very good sort of correlation or agreement, if you like, with the immunocap platform. And I mean, we see the Alex test not as necessarily only for complex patients, if you like, but it's a sort of for all patients, because we keep getting this argument that it's only suitable for polysensitized patients. But how do you know the patient's polysensitized? We need some sort of indication that the individual is polysensitized, and obviously the Alex might demonstrate that. But otherwise, you're going based on the patient's anamnesis, then you'll choose the allergens you think are contributing to that clinical relevance and test them. Whereas the Alex will give you, the whole picture, maybe also identifying hidden sensitizations or cross reactivities that might, help further down the line. And regarding pricing, that's something that's distributed. Okay. And testing, I mean, the tests, again, it's lab turnaround, so nothing I can comment on, sorry. Yeah.
Okay, I'm just checking here. Okay, so there's a person that says, I have a patient with severe urticaria for the past 5 years since contracting COVID-19 in January 2019. At the time, she tested positive to virtually every food item tested. She abstained from all these foods for a very long time, and then she was able to eat some foods in small quantities. The patient now gets urticaria and pruritus as soon as she starts eating, irrespective of what she eats. Any advice would be welcome.
Well, okay, I think that would be a super case, I would say, very interesting. It would be good if you could send that case to us, because I'd like to discuss it with our medical director. And then maybe we could sort of figure out, if they've got Alex test results on top of it, it'd be great if you could share those with us too. And then we can look into this case, in more detail. We can also arrange maybe to get some serum, sent over to us here, because it's sort of cases we like to delve in deeper and try and identify the sort of root causes, etc. But just like that now, it's too little context for me to be able to sort of provide any meaningful information. But if you could make the details available to us, that's something we would be very happy to look into further.
Okay, thank you very much. What are your recommendations regarding the use of Alex3 as a first-line diagnostic tool? Great way to test a wide array of potential allergens.
Beginning was cutting up.
Using it as a first-line diagnostic tool, Alex3?
Yeah.
I think that's mainly the question. Yolandi, can you just repeat?
What are your recommendations regarding the use of Alex3 as a first-line diagnostic tool? Great way to test a wide array of potential allergens.
Yes, I mean, we would agree with that, but ultimately the decision on which test to sort of prescribe would lie with the physician and the clinician, whether they want to. But I mean, we see it as you're getting a full sort of picture of the patient's sensitization profile, and then based on that, you can decide based on that. Obviously, you always have to, because it's important to remember that the Alex3, just like any diagnostic test, is detecting, or any SIGE test is detecting the sensitization as opposed to allergy. But you always have to take the patient's clinical picture together with the actual test results to make a proper diagnosis. But the Alex provides a more broad picture in one single step. A lot of interference.
Okay, thank you. Just scrolling to see if there's any more questions. Okay, so I think someone is saying they've got it greater than 1,200 inhalation screens test weekly positive. And then I think they're asking, is it worth testing for anything else?
So they've tested for inhalation. So, I mean, yeah, for sure. I mean, you could test to see for different cross-reactivities, for example. I mean, again, I'd have to have a look at the picture to see what they're testing, which which inhalant or respiratory allergens they're testing positive for. And then based on those results, whether it makes sense to do any additional testing. But it would have to be taken, we'd have to have a look at the results first, as well as the clinical picture, and then decide whether any additional testing is merited, if you like.
Okay, thank you. I see there's more people who are asking about the pricing. It seems they missed it. The price for the Alex testing is 4,203 Rand. And even with the Alex 3, the price will remain the same, 4,203 Rand. Let me see if there's any other questions. There are a few people who asked if the medical aid covers the cost. We will get back to you because I think it does depend on the medical aid plan and option that you are on. So we will get back to you on that one. Is there anyone else with any other questions? Let's just give a few seconds to see. Yes, how easy will the test report be to interpret for general doctors that is not a specialist?
Yes, so I didn't have this slide. It was part of my initial slide. So the report we feel is quite comprehensive. So on the first slide, you'll get sort of a synopsis, a summary of the allergen sources the patient is testing positive for. And then on the subsequent pages, this is broken down into the individual extracts or components. And then at your discretion, so at the physician's discretion, they can also request the interpretation aid. So this is the Raven 2, and this is offered free of charge. So you just request the interpretation of the results, and then together, if you input the patient's clinical picture, then it will incorporate those into the test results and give you sort of an indication of what's the primary sensitizer, information of cross-reactivities, potential therapeutic strategies you might want to consider. So it's a quite comprehensive package, we feel, that the software we offer.
Okay, there's another question that someone is asking, are you recommending this test as routine first-line screening? Isn't this against national and international guidelines? EAACI 2003 guidelines on the diagnosis of IgE-mediated food allergy, for example, recommend against indiscriminate routine or panel-based component testing without specific indication, emphasizing that testing should be guided by clinical history to avoid misleading results. They emphasize that skin prick tests and serum IgE remain the first-line tests.
So again, this would be up to the clinician's discretion. I mean, guidelines are not set in stone; they're guidelines. So it's up to the clinician to decide. So maybe you have a very, very straightforward case, in which case it might only make sense to test for a few allergens. But in other cases, it might be a little bit more complex. Also, selection of the patient into it, etc. So it's not necessarily, guidelines, but they're not set in stone. We see it that way. But ultimately, it lies with the clinician's decision as to whether they'll prescribe an Alex or some other platform, if you like.
Okay, let's see. Are there any other questions? Just give a few seconds to see if anyone has any other questions. Okay, let me see. But if we did miss your question, we will get back to you on email. Thank you very much for your time, Doctor. Thank you, everyone, for joining us. I hope you have a wonderful evening. Good night.
Thank you. Good night.
Bye.
Cheers.